right? We're going to go look in the heart. Well, what's the purpose? Why are we going in the heart? Well, we want to look, and we really want to look at the blood supply of that heart, right? We want to see if there are any anomalies, congenital or otherwise. And we also want to check the valves. Can you look at the valves? Yes, you can. You can look and see if they're stenosed or not. So that's, the purpose of the cardiac cath. Well, what's your nursing care? Well, in the ideal world, which NCLEX lives in, your NPO is 6 hours before. That's the ideal world. I'm here to tell you that in the ER, most of the times it's come in, he's got chest pain, he just ate, whoop, up to the cardiac cath lab. Okay? We don't care if his NPO is 6 hours before or not. This is an emergent procedure now. All right? But in the real, in the NCLEX world, you plan for the cardiac cath, right? Your NPO is 6 hours before. You want to check if he has any allergies. But, right? Now he's going to tell you no. Do you have any allergies? No. Do you just leave it there? No, you don't. You take it a little bit further. Can you eat shellfish? Do you like seafood? Now I've had patients who've told me that they're not allergic to anything, okay, don't have any allergies at all. And then when you go to the seafood part, they go, yeah, I break out in a rash. Well, gee, thanks a bunch. Okay? And then you ask them about their medications. You need to know these things. Are you on any medicines? Now, a lot of times they'll tell you no. And I have patients who tell me they're not on any medications. And then you go one step further and you say, do you take birth control pills? Yeah. Well, that's a medicine. Okay, so vitamins, that's a medicine. All right? Aspirin, 1 aspirin a day, that's a medicine. Hello, anybody home here? So you got to go a little step further and ask. Okay? Because a lot of people don't realize. They think it's not. They think a medicine is something that has to be prescribed. Okay, so ask these questions. And then you also want to find out if he's on any anticoagulant therapy, that he is to stop it. As I said, heparin, you stop, within an hour, he's ready to go. Okay? But Coumadin is 5 to 7 days, so generally we stop 5 to 7 days. Heparin, usually stop the day before, especially if he's on sub-Q injections. But again, that's up to the doctor. It's the doctor's discretion. So that's something that NCLEX cannot question you on. They cannot say, well, heparin, you must stop 1 day before or 2 days before, you see, because that's the doctor discretion thing. Coumadin, on the other hand, that it has, it takes 5 to 7 days, so they'll tell you they may give you a range of 5 to 7 days before, 1 week before you stop the Coumadin. Okay. You also want to check the baseline, so you will do a baseline EKG on this person. You will do baseline labs on this person as well. After the test, you're going to compare the data that you got from the test with the baseline that you have received. Now, they're going to the femoral artery, right? They're going to go right in here. So he's going to have to keep his legs straight for about 6 to 8 hours afterwards. Now, what do? We have to apply pressure to this area, because remember, it's an artery, right? It's an artery that we're going into, so we have to apply some pressure. So what we do generally, years ago, we used to use, the C-clamp at the Home Depot that you use? That's what we used to do. We got C-clamps from the Home Depot, got bioengineering to approve it, and then we just used the C-clamp. We put one part here, and tightened it. Very inhumane. Okay? But that C-clamp only cost $2. So that's what we would utilize, and it worked very well. Well, some brilliant person decided they were going to make something similar to that, and pass it off especially for medical use. Same thing exactly. Now it's $500. Well, so he's got to keep his legs straight. You've got to apply pressure. Okay, you want to watch for any possible allergic reaction, because sometimes allergic reactions can occur later. He will be on bed rest for 6 to 8 hours. Remember, I said to you that he's going to have that clamp on for 6 to 8 hours, so he's going to be on bed rest unless he can walk around with the clamps. And see, you've got no sense of humor, you guys. You have no sense of humor. And then the head of bed you have to keep the bed flat. The most you can raise the head of bed is 30 degrees. That's the very most you can raise it. And you want to push fluids. Why are you pushing fluids? To get rid of the dye. Right. You gave him a dye, remember, so you want to push fluids to get rid of the dye. All right? Let us now discuss the CVP monitoring, which is central venous pressure monitoring. Basically what happens is we put a catheter into the right atrium to determine fluid balance. Now you know that in a normal functioning heart, all the fluid that goes into the heart gets pumped out of the heart, right? That's what happens, because if it doesn't happen, then what do you have? Congestive heart failure. So everything that goes in comes out. So we put this catheter in to the right atrium to determine the fluid balance. That's what CVP monitoring is. So we're trying to figure out how the heart handles the volume of blood coming in. Okay? So what do we have to do for nursing for a person with a central venous pressure? He's actually going to have a Swan Ganz in there. Well, you know that the measuring point of that CVP is going to be in the right atrium. So what you've got to do is level out the right atrium with the manometer. Now, how many of you guys have seen this manometer? It's usually put on a pole. It's about, like that. Okay, and what you've got to do is make sure that this manometer is at exactly the same level as your right atrium. So you use a level to balance it out. Okay, here's an NCLEX question. You've got a patient who's got a CVP in. Okay, you've just leveled him out. All right, and his head of bed is at 30 degrees. You come in about 30 minutes later, and his head of bed is now at 60 degrees because he decided to raise his head of bed. What do you have to do? You've got to adjust the manometer again. Exactly. So every time, like if you have to raise his head of bed or lower it, you've got to adjust. You've got to make sure that it is level. Otherwise, you will get a false reading. Normal CVP reading is 5 to 10 centimeters of water. More than 10 is fluid overload. Less than 4 is he's dry. So what happens is if you don't level it, you'll get a false reading and you might think that he's in fluid overload when he's really not. Okay? You've got to check always, always, always check and make sure that manometer is at level with the right atrium of the patient. You've got to check the insertion site of that cath for any swelling and for any bleeding and other complications. What are some of the other complications you're going to watch for? Well, number one complication is a big oopsie. We can give him a pneumothorax, right? Inserting that catheter, we can give him a pneumothorax or a hemothorax. So we've got to watch for signs and symptoms of that. If he starts complaining of shortness of breath, that's a possibility that he could be getting a pneumothorax. Any questions so far? Write them down if you have. Okay, let's talk about cardiac enzymes. I think NCLEX has finally caught up with the cardiac enzyme picture. I'm not sure. I think it has. You've got CK enzymes, or CPK sometimes it's called. Creatinophosphate kinase. Okay. CK or PK. Well, you've got CKMB, which indicates cardiac damage. You've got CKMM, which indicates muscular damage. You've got different levels of CK. CKMB is what we're mostly concerned with. Okay? And CKMB indicates cardiac damage 4 to 8 hours after the infarct. Your LDH also is another cardiac enzyme, and so is your AST and your SGOT. The one enzyme that arises almost immediately is troponin. That is it's a pretty specific cardiac enzyme, and that rises immediately. Okay, so in other words, if he had chest pain 30 minutes ago and he comes into the ER and we draw troponin, chances are we'll see a rise right away. Okay, and it does continue to rise. So that gives us a good indication that it's probably a cardiac-related incident. Then when we get the CKMB back and the CKMB is elevated, then we can know that it's, he's got, he probably had a cardiac infarct, a myocardial infarct. Okay? Now here's the thing you've got to remember. The CKMB and CKMM. CKMM comes from muscles. So if the patient falls down the stairs and lays at the bottom of the stairs a couple of days, as can happen, yes, especially the old people who live at home, and he's found by EMS and brought in and you draw blood level on him, and you find out that his CKMM is 2,000, don't panic, because it's because he fell down the stairs. Okay, but what you need to watch for is the CKMB and the troponin portion. All right? That's more specific for cardiac enzymes. Troponin is the cardiac enzyme that NCLEX hasn't quite caught up with yet. Okay, they're still testing primarily, when they give you test questions, they're questioning you primarily on CKMB. Okay, Okay, but troponin is another cardiac enzyme. They may have caught up. I'm not sure. I heard a rumor they had. We'll see. Okay. Thallium imaging is also known as cold spot or myocardial imaging and thallium scintigraphy. Okay, here's how it works. It's very easy. See all these big fancy names? Thallium scintigraphy, yada, yada, yada. All right. It really is a very simple procedure. How many of y'all know how a thallium imaging procedure works? Simple. Really simple. You inject some thallium, okay, a radioisotope. So if you're injecting a radioisotope into a person, do you need a consent? Yes, you do. Do you need to check for allergies? Yes, you do. Okay, so you'll need a consent. You'll need the allergy check. So what we do is we inject the radioisotope of thallium-201 into the body. And then about 10 minutes later, we take a look at the heart. Okay, so under fluoroscopy, we look at the heart. Now, the areas that thallium should be taken up by all the blood vessels. The areas where thallium is not taken up will appear as little white spots. And that's what we call cold spot. And those are the areas of infarct. It's very simple. See? And you all saw it was so complicated. It's the simplest procedure in the world. And it can be done in a resting state or after stress. So what's the purpose of the thallium imaging? Well, we want to know where and the extent of the MI. That's very important. We also want to evaluate the patency of grafts after heart surgery. Now, how many patients do you know who come and say, well, I had a stent or I had a cabbage times 3 or 4? Well, what we do is, when you do a cabbage, which is a coronary artery bypass graft, what you're doing is you're bypassing the occlusion in that coronary artery, right? So they'll do a thallium test afterwards to make sure that the area that previously showed up as a white spot no longer shows up as a white spot, because now we've done the bypass and we're revascularizing that particular section of the heart. Does that make sense? Okay. One of the other reasons that we use thallium imaging is to evaluate if anti-anginal therapy is working or not. Remember, what is angina? It's a pain, and it's caused by a vasospasm, right? So when you have a vasospasm, you deny a particular area of the heart of blood, and so theoretically that now is a cold spot. So what we do with thallium imaging is we'll give anti-anginal therapy, and we'll do the thallium image, and we'll stress the patient out, okay, and we'll see if indeed this worked or not. Okay, you've got two different types of thallium imaging, stress and resting, okay? For the stress test, you need a consent? Absolutely, okay? You want to tell them no alcohol or tobacco for 24 hours before. Why? Because both alcohol and tobacco can throw off the results, okay? It can cause a problem, so you don't want him to smoke or drink for 24 hours before. Are they? Yeah, sure, they're very compliant. Yeah, Okay, you want to tell them also to be NPO after midnight, just in case. Just in case what? Just in case we do the thallium imaging and we find out that, oops, we might have to take him right away to the OR. Okay. Tell him that he's going to receive that radioactive tracer, okay, and no, he will not glow in the dark. You need to tell him that, because sometimes they think they will. No, he will not, okay. Tell him that for the stress test, he needs to use comfortable shoes. Women, please tell him to wear sneakers. Don't come in with your high heels. It just won't work. Okay, so nice, comfortable shoes. And tell the patient that the second that he feels any pain or shortness of breath or any fatigue, he is to let you know immediately. Okay, don't be super macho. We had a guy who did that. Okay, he had chest pain, etc. He was on a stress test. And we, kept increasing the treadmill and everything. And after a while, he put his hands on the handlebars and lifted his feet. And he said, I am no runner. Why are you making me do this? I am no runner. Well, we're not trying to find out if you can run, sir. We're trying to find out the condition of your heart. And he just absolutely refused to put his feet down until we slowed it down. So he was a failure. We could not get the stress test done. So we ended up having to we sent him home. We said, come back when you can. Okay. I don't know if he's alive or not. Anyway, Resting imaging. Or with resting imaging, we generally do resting imaging after a patient